Vitamin Water Zero Sugar has great taste, zero BS, and obviously, zero sugar. For those with zero room in their calendar. Zero patience for slow walkers. Those who get 0 hours of sleep on a Saturday night. Have zero filter, zero given, and zero interest in grabbing a plain, boring water. Grab a delicious Vitamin Water Zero Sugar today.
It's back to school season, and Clorox is donating 2 million disinfecting wipes to classrooms across America. Because back to school means things can get a little bit messy. Just ask kindergarten teacher Miss Gibson.
Give me just one Clorox wipe and I'm ready for glitter glue, exploded lunchbox yogurt, peanut butter handprints, runny noses, picking noses, rubbing noses.
Touching noses.
Thank you, Edward. Ooh, nap mats and lockers and tissue boxes. And
Clorox
scissors.
disinfecting wipes. Teacher's #1 wipe. Clean feels good. Based on unit sales data.
This is Addiction Medicine Journal Club. I'm Dr. John Keenan.
And I'm Dr. Sonya Tredici.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. The podcast offers 1 CME credit through MyCares and Michigan State University. The link for the CME are in the show notes. This week, we are going to be discussing how a pregnant person's buprenorphine dose affects neonatal opioid withdrawal in the baby. How are you doing tonight, Sonya?
I'm doing great. How are you doing, John?
I'm doing good. Just kind of, as we know, end of the night here, last recording for the evening, muscling through.
No, think of it as we're hardcore. We're like just getting started. You know, take it back to your college days where you would have like study groups starting at 10 p.m.
I had I'm in class right now. I was in my statistics class last night, and it was after like my MAT clinic or my MAUD clinic, and it was a long overbooked day that I ran into afterwards. I was drinking a Red Bull, and the teacher was like, normally I don't see the graduate students. Like I was on Zoom. He's like, I don't normally see the graduate students pounding a Red Bull in class.
Yes, they're more relaxed. Oh my gosh. How'd that do for you when you try to go to bed later?
I mean, I went to bed I go to bed like 12:30 or something like that. I feel like I just get sleep deprived throughout the week, and then like I get a reset over the weekend. But by Friday, I'm on fumes.
Yeah. That's one of the things about getting older is you can't do that. So like, I can't make it up. I just have to sleep every night. Can't catch up anymore.
Yeah.
Well, hey, speaking of fumes, I wanted to share an interesting article with our listeners.
It's a good transition.
I know, right? It totally natural too. I was poking around in a gas station up in Tioga County, way up north, gas station / drug paraphernalia store. And I was kind of amazed at all the nitrous oxide they were selling. So there was a whole zone of Galaxy gas in this gas station, which is a product, for culinary use if you're going to make sort of bulk whipped cream. And it comes in different flavors, so you can make like flavored whipped creams. And they're selling it, of course, at the gas station / drug paraphernalia store. And they also were selling small, individual canisters, like little whippets or little sort of bullets that you would put in a, your home whipped cream maker. And then these giant canisters for industrial use. And then my sort of starting to research, nitrous oxide led me to an article in the Smithsonian magazine, which was published recently about the history of nitrous oxide in the U.S., which is very fun. I like the article a lot. It's, open access. I'll share a link in the show notes if anyone wants to read the whole article. But a few fun facts about nitrous oxide. So just in case anyone doesn't know, it inhibits the NMDA receptors in the brain, triggers a release of endogenous opioids, but also gives you this disassociation and euphoria. You get pleasure, giddiness, a feeling of being outside yourself. It's short-lived. Also, it weirdly deactivates vitamin B12. I don't know the mechanism. And we all know that B12 deficiency, we all know what that does over the long term. So it was first used in the late 1700s, very long time ago, when chemists, doctors, and artists sort of experimented with it and then reported on their own experiments. This was in the time when, a researcher would first research on themselves. And then in 1844, it started to be used with dental extraction. So a dentist used it on himself while someone else extracted his tooth to see if it would work. And its use as a dental anesthetic was born. It was a big flop as a surgical anesthetic because I think when they tried it in surgery in a big demonstration, the patient woke up mid-operation because it's relatively short acting. That didn't go very well. But now it's basically sold for two purposes, dental and culinary. Um, but of course, the
They
giant
use it in
canister
pregnancy too.
for anesthesia.
Yeah,
There you
that's one of the
go.
options. No one ever picks it, but it's there.
It's hard to enforce a reason that a store might sell something. So the head shop can put a sign for culinary use only next to the canisters they're selling. And there we go. That's the reason. So I'll put a link to this article in the show notes. But John, have you seen any issues with nitrous oxide or any of the inhalants in your people?
I feel like when I kind of take a substance use history, that's always kind of like after note in some histories where it's like something that was experimented with. I've never had someone with a long-term nitric oxide problem that I've ever remember hearing about or talking to. And that doesn't mean don't exist; just means it's not as common.
Yeah, I think those people don't come to treatment so much. It's particularly stigmatized, like even among drug users. If you're using inhalants, it's very kind of low brow, maybe. And then nitrous oxide has such a short effect. I don't necessarily think, I mean, some people do, of course, run into problems with it, but I don't think quite as dramatic problems as, say, fentanyl or methamphetamine. So I think it stays under the radar a bit. But it's definitely not good for you. It's not good to inhale high dose frequent nitrous oxide. So just so everybody hears that from us. John, anything interest you in addiction medicine news this week?
It's interesting, like these articles come in clusters, and this is from AMA Journal of Ethics. It's about private equity, and it's called Health and Equity Profiteering by Private Equity Firms. And you and I were just speaking at kind of a conference at VCU, and one of the really awesome presentations actually came from a medical student where he's one of the MD PhDs, and I want to say their third year, but I forget his name too off the top of my head. So, but the presentation was excellent,
Whoever
and it
you
was
are,
about.
we loved your talk.
I feel terrible now, but and it basically was about how private equity was taking over methadone clinics and kind of what that looked like in the United States, and it was very kind of appalling how much stake that private equity was taking in the methadone market, and in fact, it was most access to methadone requires you to go through private equity, which is kind of crazy. Um, and so, private equity gets a really bad rap for many reasons. Typically, anyone not familiar with that term, it's basically a private investor group that's coming in to kind of run a healthcare facility. It's a for-profit healthcare entity. Um, and so oftentimes they talk about the private equity playbook, and the private equity playbook often involves kind of like buying a failing business or service, cutting anything that's non-revenue generating, so any accessory support services, leaving just the build services behind and treating a profit in the short term to resell it and then typically get out of that industry or out of that potential business. So it's sort of like a house flip. You're kind of putting in kind of like builder's grade stuff to make it look nice and sell the house, and then you're out of there before the wall collapses. And basically, they talk about the fact that that they cut costs, oftentimes with kind of our mental health and substance use treatments. That often looks like case management, social work, counseling, so kind of the non-revenue generating aspects, peer support, recovery, and you're leaving just behind build services, which is typically your clinicians, kind of like your physicians and APPs. And there's currently no real regulation. There's no transparency. I know even in Pennsylvania, I know that there's been multiple kind of posts about them trying to regulate to push private equity out of healthcare in Pennsylvania, although it's something that legally isn't something that can be done. It really also disproportionately affects our kind of most vulnerable patients. So that's typically incarcerated patients, people with substance use disorders, low income patients, not kind of banging on anyone, but certainly our dialysis services are notorious for this as well. So kind of groups that's like captive audience that doesn't have other treatment options. So it's kind of like a very vulnerable population. And really, the article just highlights the fact that these kind of organizations seem to be rising around, especially with kind of a lot of volatility in the business of healthcare currently. We're seeing more of them, and not only are they monopolizing, but they're unregulated, and it really puts our most vulnerable patients at risk. And so, it's a call to action that hopefully we can get some transparency and laws for public protection from some of these entities. And I'm sure not all of them are predatory. So I hate to like generalize a group. I feel like we're just banging on insurance companies, now we're banging on private equity. Maybe there is some good spirited people out there, but certainly the private equity playbook is buy, consolidate accessory services, kind of gut the car down to the bolts and then sell.
Well, right. And the problem is once these community services have been dismantled or gone out of business, if private equity, that's what happens with some of the methadone clinics, like they took a long time to build. It's not like, given the regulatory environment, you can't just like open a community health center in one day. You need to bring staff to the area. You need to have, meet all these regulations. So if private equity comes in, consolidates, closes, small branches, you can't get them back very easily. I think that's part of the issue. It's like if it was just buying and selling a business and you could just restart it again, fine, but you can't really, And I think to me, that's one of the biggest concerns. I think about our small rural hospitals who are all at risk for going out of business if Medicaid is cut. We're not just going to be able to reopen them in 3 years if we have more Medicaid funding. It doesn't work that way. Like, you can't have a hospital without doctors, and if you close the hospital and all the doctors move away, you're not going to be able to find 100 doctors to move to your rural community again. Like, that takes decades to build that up. And so I think that's part of the problem. We're not just trading widgets,
Yeah. So let's hear about this really interesting article on your crusade for neonatal abstinence syndrome and how to minimize this.
I know there's a theme here. And of course I'm internal medicine, so I do see pregnant women, but I don't know. I'm not family medicine. I'm not OB. I mostly see non-pregnant people, but I've definitely been very interested in this issue, and I've been interested in people's experiences as they go through pregnancy. So this was a great article. It's very interesting, and it was called "Is Buprenorphine Maternal Dose Associated with Neonatal Opioid Withdrawal Syndrome Severity?" Published in the American Journal of Addiction a few months ago in January of this year. So this article is important because having a newborn who's sick with neonatal opioid withdrawal syndrome is one of a pregnant person's main concerns when they're on opioids. They worry that that's going to happen. They don't worry so much about themselves, but they worry about the infant. And, common wisdom holds that pregnant people should not go through withdrawal during pregnancy. And I agree to an extent, which is that pregnant people should not be destabilized and be put at risk of relapse. But there's a little bit of a myth about how bad withdrawal is for the fetus. There's this sort of thought that the fetus could die if you go through opioid withdrawal. And this really is based on a very limited number of case studies. And there's an overwhelming amount of data on withdrawal in pregnancy showing no fetal harm. But regardless, we strongly counsel women to avoid opioid withdrawal. And we counsel them to stay stable on their buprenorphine at all costs, because a realistic fear is that they could relapse. And finally, if you listen to some of our other episodes, including episode 55 about the pharmacodynamics of buprenorphine in pregnancy, you would have heard me talk about how many pregnant women need to increase their dose of buprenorphine in pregnancy to maintain like a stable blood level. So we've got 3 forces that encourage people on bup to stay on their dose or raise their dose in pregnancy. But what many of my patients have asked, and this seems very reasonable, is shouldn't I decrease my dose so that I have less risk of neonatal opioid withdrawal? Because you'd think more buprenorphine equals more withdrawal. And to me, that's a very reasonable question. And a lot of people have asked that question. And in previous studies, it hasn't seemed like there was a strong correlation between the dose and the incidence of neonatal opioid withdrawal or the severity of the withdrawal. There is a strong correlation between methadone dose and neonatal opioid withdrawal, which is a full opioid agonist. That's been well established. But buprenorphine is a little bit different. Buprenorphine has a unique pharmacology, and I'm sure you've seen this too, John. It's obvious that people respond very differently to it. Like, I have people getting the same clinical outcome from 2 milligrams a day and 24 milligrams a day. The doses needed to get the full clinical effect vary really widely. And so I could imagine that a infant's experience with withdrawal would also vary widely and not necessarily be correlated with the dose. But the real reason I chose this article to present is that it's spoiler alert, it showed that there was a strong connection between dose and incidence and severity of neonatal opioid withdrawal. And whenever I see an article that's different from what I assume or sort of tells me something new or challenges my assumptions, I always try to pay attention. And that's why I wanted to present this article. So before we go any further, John, do you ever have people ask you if they should reduce their dose of buprenorphine in pregnancy?
We do talk about this from time to time. And I guess but I guess the conversation's just phrased a little differently in my office. I'm a family medicine doc, not an internist. So like a lot of my training, like in the inpatient realm, was in pediatrics. And over the years, I took care of a lot of these kids when I was in my pediatric inpatient rotation. I felt like I was at a community hospital. I feel like, if I had to summarize my inpatient pediatric rotation, it's like and RSV, and then it was like, neonatal absence syndrome or now. So I feel like that was like probably those two together were 80% of the cases, lots and lots of RSV and nows. And I feel like I just view this as a physiological response. Um, and and I don't feel like anything that I've seen with that experience is a reason for me to alter care for a patient. And I'm very kind of straightforward with them. I think Kathy, my CRS, gets tired of me saying it, but I always kind of tell people, I'm like, when the oxygen mask drops, you put your mask on first before you help someone else. And I really think that prioritizing stabilization of the mother as the best outcome for the child is actually the best. And actually, a psychiatrist, ironically, was the one that kind of got that verbiage in my head. Like, well, no matter what we do, healthy mom trumps all, right?
Yeah.
Who knows about like a possibly teratogenic medication in a mentally unstable patient?
Yeah, and I mean, I do agree with you, and you certainly don't want to destabilize people. But I've had quite a few super duper stable women who really don't want to have, a newborn in the NICU or, in our hospital, we don't really do NICU anymore for nows, but don't want to have a sick baby. They want their baby to come home when they leave the hospital, and they feel guilty if they sort of hurt their baby right out of the gate and have asked about what can we do to kind of minimize this. So this study addressed that question. So population is full-term infants born to mothers who received buprenorphine during pregnancy, and they had to be admitted for nows, and they used something called a Lipsitz score of 4 or higher. We don't tend to use that Lipsitz score too much in the U.S. anymore. To manage nows, we use either something called the Finnegan method, or our hospital, St. Max's, we use Eat, Sleep, Console. But this study was done in France, where they still use this Lipsitz score, and I think of it kind of as the baby cows. It's used to assess an infant's withdrawal. So it looks at like tremors, irritability, reflexes, they're pooping, they're peeing, muscle tone, are they scratching themselves or rubbing on the bed? So abrasions, respiratory rate, that kind of thing, sneezing, yawning. So you do the score, and based on the score they get, you give them a little dose of opioid agonist to help with neonatal withdrawal. So the study is infants who had this high Lipsitz score, meaning they did have neonatal opioid withdrawal. They excluded infants if the parent was on benzodiazepines or other opioids, including methadone, illicit opioids, or prescribed opioids. It was done over a 10-year period to get enough people. It included in the end 80 infants. And another difference between France and the US, these people were on very low dose of buprenorphine. So 34 of the 80 infant parent dyads were on low dose, which meant less than 2 milligrams a day. 32 were on medium dose, which is 2 to 11 milligrams a day, and 14 were on high dose, which is greater than 12 milligrams a day. So in our world, high dose is like 24 milligrams a day, 16 to 24, and medium would be 8 to 16, and low would be less than 8, I feel like would be my divisions. But overall, their doses were much lower. All three groups were similar at baseline in terms of baby stats like birth weight, length, APGAR scores, head circumference. And they just looked at the infants exposed to the low, medium, or high dose buprenorphine, and the outcomes were nows. So how severe was the neonatal opioid withdrawal? How many days did they suffer from it? And then the secondary outcome was how much morphine did the infant receive? What was the length of treatment? What was the length of stay in the hospital? And how long did it take them to regain their birth weight? So that's the clinical question. John, what did you think of the clinical question?
I think it's very kind of patient relevant. I think kind of just looking at this off the bat, I don't think I kind of, until I looked at this on paper, appreciated during our live journal club how different those dosing ranges are compared to what like I see. You know, the fact that 66 out of 80 of them were under 11. The majority of the study was doses far below what I would typically use in my clinic for these patients.
Yeah, that definitely like hurts our generalizability a little bit. So is this trial valid? It had a bunch of strengths. So all three groups of infants were similar at baseline. There was no funding that would cause bias. There was no conflict of interest. I thought the statistical analysis was appropriate. And basically, it was an easy to understand, relatively simple trial. They looked at maternal buprenorphine dose and how many days of NOWs did the baby have. There were some limitations, though. The first is that it was a prospective cohort study, and of course, the groups may have been different at baseline. They did collect some maternal demographic data as well, but didn't necessarily put all that in the paper. Um, I really thought, the incidence of NOWs is affected by things beyond just the presence of opioids. So maternal mental health medications might affect it. Just for example, so you would want to know were there other medications present that also could cause withdrawal in the baby. They didn't adjust for all different pregnancy factors as well, like mental health medications, socioeconomic factors, and they did collect some data, but they didn't report on it in the paper. So again, this is the problem with a prospective cohort study. You're never sure that all the groups are the same at baseline. And finally, it was relatively small. They had to divide into three groups. And in the end, there were 80 infant parent dyads. And then with three groups, each group ended up being relatively small. So I thought that was a little bit of a limitation. And finally, like we said, it's different than we have in the US using the Lipset score and using low-dose buprenorphine. We use Eat, Sleep, Console, and we use much higher doses of buprenorphine. So it's, in the end, once I read this paper carefully, it's a little hard to compare it head-to-head with our care in the US. So John, did you think that the trial was valid? Can we use the conclusions?
Yeah, I mean, I think kind of minus the dosing range discussion earlier on, I thought it was pretty valid. Certainly seems like very similar overall. Minor change in protocol from the United States, at least that what I see, but I don't think that would make a difference in terms of extrapolation of this, right? Those are all validated assessments.
Yeah, totally. So results, bottom line is that the increased doses of maternal buprenorphine were correlated with increased duration of NOWs, maximum dose of morphine, and length of stay of the infant. So a few numbers. In terms of the duration of neonatal abstinence, the low dose group, so less than 2 milligrams a day of buprenorphine, so very low. So less than 2 means 1 milligram a day or less. Duration of NOWs was 3 days. The intermediate dose, so 2 to 10 milligrams of bup, length of NOWs was 7 days, and high dose length of NOWs was 17 days. So just a real difference, 3 days, 7 days, 17 days. In terms of the duration of hospitalization, those all tracked too, because of course, any baby with NOWs had to stay in the hospital. 8 days for the low dose group, 15 days for the intermediate dose group, and 20 days for the high dose group. And remember, these are all infants who had NOWs. So it's more about NOWs severity. It's not about NOWs incidence. And finally, maximum dose of morphine also tracked right along with that. So low dose, intermediate dose, and high dose had increasing amounts of morphine needed. So yeah, basically for babies who did have NOWs, the NOWs was very strongly affected by the maternal buprenorphine dose. So will these results help me in patient care? I think they will. Like the outcome was clinically relevant, including duration of hospital stay. The research is a little hard to apply in my setting since, again, France has different buprenorphine dosing. And it's kind of hard. Like if I'm saying, can I apply an article to patient care? I want to know what the risks are and the benefits to the intervention. So I've got the benefits, which is less neonatal opioid withdrawal syndrome or shorter at lower doses. But what about the risks of a lower dose of buprenorphine? We didn't really cover that. The woman here, the birthing person, is just a vessel for the baby in this study. And there was no data on maternal outcomes based on buprenorphine dose. So what if people on the lower dose had multiple overdoses during the course of their pregnancy or something? Like that kind of data was not reported. And so you can't really give the patient a risk-benefit calculation about whether they should go on to, let's say, a super low dose buprenorphine to avoid neonatal opioid withdrawal syndrome. So bottom line, um, increased dose of buprenorphine during pregnancy is correlated with the severity of NOWS in those babies who do get NOWS. It gives support to the decision to reduce buprenorphine doses during pregnancy in stable patients if the patients would like to, but I didn't feel this study was strong enough to have me make a blanket recommendation. And like you said, I probably will prioritize the stability of the parent over the risk of NOWS, because while it's no fun to have a baby in the NICU or have a sick baby, like you said, John, it's a reversible condition. It's treatable. It's time limited, and there doesn't seem to be any long-term sequelae of this. So, do you think this study will change your practice at all?
Um, Not particularly, to be honest with you. I mean, I feel like, physiologically, this has always made sense, especially with this dosage range. I think this is kind of like giving further validation to probably like a feeling I already had that the dose did correlate to this. You know, in medicine, 90% of my job is managing expectations. So I think it's probably useful in the fact that I can kind of better counsel patients about this. Certainly, pregnancy, newborns, those are very stressful times for women and for dads too, right? I mean,
Yeah.
so it's a stressful time at the house. Um, I don't know if that's a great time to be talking about dosage alteration, down at least. Certainly, I'll work with someone if they feel that way, but I think prioritizing their own health is still the best way of prioritizing the baby, right? Healthy mom, healthy baby, and a lot of the dangers from opioids, right? It's not the opioid, right? It's the up and down, it's the physiological stress that induces into a pregnancy. And so I guess that's another question, like, is the stress of a taper, does that outweigh the benefits of a reduction for nows? I mean, I don't know. That'd be another self follow-up question, right?
Well, right. What there's zero data on is, I mean, of course, you're not going to do a randomized controlled trial, but even a prospective cohort study of the outcomes for people who tapered buprenorphine during pregnancy and how they turned out. You know?
Let's rephrase the question. SSRIs cause neonatal abstinence syndrome, right? So withdrawal
Hmm.
is common in children. Do we ever talk about the need to taper an SSRI in a stable woman with depression or anxiety? I mean, the conversation doesn't really even enter into most discussions, I would say.
Does it to mine when I'm talking to women.
Do
I mean,
you?
well, this is a totally, tangential, but I feel that SSRIs and SNRIs are way overprescribed and are less effective than we think. And I feel like a lot of patients should reassess whether they even need them after they've been on them 6 months or a year. Um, a lot of people go on kind of autopilot with them, and 14 years later, they don't even know if they need them or not. So I like, if someone tells me they're pregnant, I do assess all of their medications and I sort of say, do we need this? Do we not? Is there any sort of pregnancy risk? Is there not? And SSRIs are in that category of things that if you don't even know if you need it and your mental health has been very stable and you had one episode of depression 14 years ago, maybe you do want to try to stop it for a few weeks and see how you feel. I mean, I always give people the option. I'm like, stop it for 2 weeks, see how you feel, go right back on it. If, do a little taper, go right back on it if you um, need it. But yeah, I do talk to people about it.
Yeah, it's interesting. I mean, most of the data would show that you're right. The 6-month trial, I do stick to that. That's the current guideline recommendations, right? 6-month reassessment. Although, when you look at relapse rate after the first episode, right, it gets very high very quickly. And I feel like, I don't know. I think that like the relapse rate after the third episode is almost 100% for depression. And it's like 3/4 to 80%, I think, after the second episode. So like besides that first time, I often don't find that, the tape of discussion for that medication class is super useful. But in the same token, there's MRI data about brain volume improvements with people that are treated with SSRIs over a lifetime with depression. So I don't know. I feel like maybe I should talk about it, but I feel like we're much more likely to talk about these like stigmatizing medications than that, which most people
Yeah.
think is benign.
Well, and this stemmed from a patient I had who had opioid use disorder and was on paroxetine or something. I forget what she was on, some SSRI. And she had her baby had severe opioid withdrawal syndrome, was in the hospital for like 3 or 4 weeks, like really prolonged time. And she was really angry that she felt like the risks hadn't really been explained to her. Not necessarily the opioid withdrawal, but that the other medications have made it worse.
Well, the Paxil's class D, right? That's an
Yeah,
outlier. That shouldn't be
it wasn't
continued at
Paxil,
all.
but it was some other like SSRI. But yeah, I feel like that she really felt like the
Or
risks had,
anything.
or ever. Oh my gosh. But no, she really felt like the risks had not been shared with her. And she really suffered, and the baby really suffered. So I do try to talk to people about it.
All right. Well, so we got some comments from listener David Sirota about episode 60, which is about lisdexamphetamine for methamphetamine use disorder. I thought this would be conversation generating, and I thought it might be somewhat controversial, since I know that there are a lot of people that do this. And I feel like we've talked about this every so often. We enter a room and someone's talking about this like it's just a thing. And I'm like, is this, wait, what, you're doing this? But they talk about it like it's like, drinking 1.5 liters of water a day. I'm like, wait, you're doing that?
And
And
we
it
got
says
a
that,
bunch more comments. Let's just say I just chose the ones that I thought were like really good.
oh, really? Was there negative ones?
Well, no, they weren't negative. It's just a lot of people had a lot to say, but these are the ones that really kind of addressed the article itself. So
Am I in danger?
that's you didn't give out your address, did you?
It says, I love the episode of lisdexamphetamine RCT for methamphetamine use disorder. The results were pretty underwhelming, unfortunately. It tracks with my experience the few times I've prescribed stimulants for people with stimulant use disorder, which is that people tend to like it, but I haven't noticed much decrease in the use of illicit stimulants. I came across this article, which is still in preprint, but it just highlights how much stimulants people with methamphetamine use disorder are getting into their body. The estimate was a median of 500 milligram equivalents of oral amphetamine per day among people with meth use disorder. So even lisdexamphetamine 250 milligrams might be less than half of what most people are taking. Finally, I feel that there is still the possibility that the outcome shows are hiding significant benefits. I'm just thinking how there is a spectrum of how much someone is using meth in a day, from taking a single puff of meth and going to work versus injecting meth 12 times a day and stealing from a store. We know that certain meds like naltrexone for alcohol use disorder are most effective for decreasing heavy drinking days rather than complete abstinence. Do we have any equivalent measures for stimulant use disorder rather than pure abstinence? I think that's the debate, right?
Right. Well, yeah, and I've seen some of the methamphetamine research is like, how many days a month did you use methamphetamine? That'll be an outcome, and there'll just be a reduction rather than complete abstinence achieved.
Yeah. It's hard. I mean, I don't know what the right answer is. I mean, like, it seems underwhelming, like those previous results. I feel like, first tenet in medicine is do no harm. I feel like, we do know that stimulants over a long period of time do have cardiovascular risk, right? That's a new recommendation for counseling prior to initiation, is that patients acknowledge the cardiovascular risks of these medications. Even though it's a small increase, it's statistically significant. And those are our more classical doses, right? So like the highest dose of lisdexamphetamine that's kind of FDA approved for ADHD is, I believe it's 70 milligrams.
Not
So
sure.
anything else is off label beyond that. I believe it's 70. So this is 4 times that already. Now we're going up to 8 times that. I just feel like, I don't know.
Yeah.
Seems like a potential.
Well, and if you give the methamphetamine equivalent, then you're going to have the same health problems you get from using methamphetamine.
Yeah. It's hard. I have a patient in the hospital right now. It's kind of like, young person kind of illicitly using stimulants, and, they got a cath and a stent out of that. So they had kind of severe vasospasms and coronary damage. The other thing was from Veronica Lee about the same episode. The main outcome didn't hit statistical significance. Only about half the participants stuck with it through the end. And a lot of the data was self-reported, so it's not quite ready for prime time. Promising, but we'll need larger, longer-term studies before this could be considered a standard treatment option. Yeah, I agree.
Yeah, agreed. Well, thank you everyone for those comments. Keep sending them in.
Math is still like the thing we all see, which we don't have any true solution for, right? It's like mechanical back pain. It's like we see it all every day, yet everything we have is very underwhelming.
Yeah, it's true.
Well, thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about the articles included in a future episode, send us your comments on social media, email, or join us on Facebook. The links are in the show notes. Our original theme music was composed and performed by Benjamin Kennedy, audio editing by Michael Bonanno, CME support from My Cares, produced by Dr. Patrick Keenan and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation and have a great day.